vaccine distribution in diverse and underrepresented Latinx communities. This is a joint LMSA and MOLA event. So for anyone who does not know what MOLA is, it's the Medical Organization for Latino Advancement. I just wanted to say that I'm very appreciative to be given the chance to work with them. My name is Nabil Baig. I am a first-year medical student here at the University of Iowa, Carver College of Medicine. With me today, my colleague is Jose Alberto Figueroa, and he is a former MOLA intern and actually an incoming medical student. So good for him. When deciding to come up with this program, we wanted to look at a hot button topic such as the COVID-19 vaccine and its distribution, but we didn't want to just look at one area. We wanted to look at multiple areas such as in Iowa City, such as Johnson County, Dane County, Wisconsin, and Chicago itself, because we recognize that the Latinx communities here, while they're similar in composition, they're very geographically different, and this may present itself in differences in the social determinants of health. So most notably, we wanted to focus on the access to healthcare that these communities have, and we hope to delve deeper into that in the context of the COVID-19 vaccine. So with us today, we've amassed an expert panel to speak to us. First off, we have Dr. Geraldine Luna, who is the medical director of the Chicago Department of Health, Public Health, and part of the COVID-19 task force. We have Dr. Lord Shanjani, who is the bilingual health education coordinator in public health medicine and in Dane County, and Dr. Jorge Salinas, who is the hospital epidemiologist and clinical assistant professor in internal medicine and infectious disease. So the way this program is going to go out is that we're going to have about 5 to 10 minutes for each speaker to speak about topics that they feel is important within their communities. And at the end, we're going to have a Q&A session. So if you have any questions, please type them into the chat. We're monitoring, and we'll ask them at the end. So without further ado, we can have Dr. Geraldine Luna start us off.
Okay, thank you, everyone. Can I share my my slide deck?
Yes, you should have access.
I do? Okay, perfect. So let's go very quickly here. Can everybody see it?
Yes.
Thank you very much. So thank you for having me here. It's an honor, especially when we're talking about barriers and medical mistrust and equity and the way we have done it so far with the vaccine. And just a reflection of the fact that this COVID-19 pandemic has disproportionately affected people of color in this country, especially Latinx communities and African Americans. So I'm the medical director of the Chicago Department of Public Health. And when we're talking about the race ethnicity, and I'm going to be talking mostly in the city side, since I know it's Cook County, so it's pretty much broad city side, but since I'm at the Chicago Department of Public Health, all the information I want to share with you today is mostly regarding the city and approaches that we have taken for vaccination hesitancy, the distribution first, and now presenting resistance and hesitancy, and I'll share with you the situation that we have here in Chicago for awareness. In Chicago, we the way that we have our race ethnicity breakdown and distribution that we have in the city is that white individuals are 32% of our total population. Hispanics is 28.7%. And Blacks, and we're talking about African Americans, are 30.9%. And then we see our Asian communities and other communities represented and distributed here, including our Native Americans in this representation. And from those, just quickly approaching this, okay. So when we're talking about the situation in COVID, and it's worth mentioning right then, it's because of the disproportionate affection that we have seen And it's not difficult to explain, given the years and centuries of systemic discrimination and racism, very, very grounded and embedded. We were not part of our Constitution when they were writing it, and systems, years went by, and being considered like a second-class citizen, it has taken toll in our health, and this is pretty much an important part or everything in terms of equity in the public health department. So when you look at that map, look at the distribution, these are the hotspots of COVID-19 in Chicago. And we can see mostly everything is in the West South. And you can see like very low, it's anything that's white or, the inclination to white, and medium is that light blue, and the very dark blue is everywhere where the devastation has happened the most. Outbreaks have been the rule of the day, and death and mortality represented in our indicators. So we move very quickly here. Vaccine administration has been like the light at the end of the tunnel, and I guess it's for every county right now, for the nation. And we're seeing how our how other countries, like for example India, right now are suffering a tremendous devastation, and we have seen the trends along the pandemic a year after our first case was reported here in Chicago from a nurse from an African-American background origin. So if you look right now in the Chicago, in the city of Chicago, we have vaccinated 2.2 million, more than 2 million individuals have received at least one dose of the vaccination. So it looks like one of every two, the way that if we're going to see it in ratio, it's one of every two Chicagoans 18 years and older have received at least one dose of the vaccine. And then when we're talking about 65 years and older, we have one of every two Chicagoans that have received the vaccine. So this is the way it looks. So just by looking at that, you see that we're pretty much halfway vaccinating our population, which is composed of 2.7 million of individuals here in this focus here in Chicago. And right now we're vaccinating everyone. So we're past phase 2, everyone is eligible. There is no restrictions the way that we have done it right now. And as stunning as it sounds, like right now the supply is higher than the demand. And the uptake of the vaccination has decreased in Chicago 25% when we're half there vaccinating. We think an important point of this new trend of the community, it's because of the Johnson & Johnson reported cases of very rare clots happening in the population, especially in women younger than 50 years old. But this is a new trend that we have. We're sitting pretty much on vaccines, and we have our population, Latino and African Americans, we're falling behind in vaccination without walking into our city sites, our pods, our strike teams. We're doing events with the faith, which is a faith month in April here in Chicago, and people are just not walking in to get their vaccines. So this is where we are right now. 16-year and old can vaccinate completely free. There's no need of presenting evidence of even being a resident in Chicago. You don't even have to make an appointment. It's free for everyone. Walk-ins are permitted. Right now, we have one of our massive vaccination sites, and I'll explain a little bit more, presenting the model that we have here, taking care of our communities, is a massive vaccination site with capacity to vaccinate 6,000 individuals. And it's only running at 1/5 of its capacity to vaccinate. We're talking about the Chicago State University, to the point that if our individuals don't get sooner to vaccinate, we'll start pushing everything the usual way of vaccination, using our previous vaccination infrastructures that we have here in Chicago, because it's not worth just sitting there waiting for individuals. And I'll give you more about the approaches and initiatives that we're trying to attempt to bring more individuals to get vaccinated, kind of give them perks and move from there. So our prioritization criteria, which was before and now we don't have a prioritization criteria. Everybody's welcome. It was based on science, implementation, and equity. And by science, we're talking about the epidemiology information that we have out there with COVID-19, the incidence, mortality, and morbidity. And we were assessing at the time potential harms versus benefit of vaccination when the vaccines were limited resource. And we had to prioritize in terms who needed it the most upfront and give it to those individuals. When we're talking about implementation, we were taking into account feasibility of vaccination of this group and how this group value and accept COVID-19 vaccination. And a lot of effort from the city was put into communication in the right linguistic and cultural manner to make sure that our populations, all our populations, especially our most vulnerable, which are Latinx communities and African Americans, were able to access the information in the right language and cultural background to support, to give meaning to these communications. And then when we were talking about equity, we were talking about moving ethical principles of maximizing benefits, minimizing harms, promoting social justice to the communities that were more highly hit by COVID-19, and mitigating health inequities that we saw since the very beginning of this pandemic. The city has received, to this point, was receiving our vaccinations directly from the federal government, not even from the state, because there was a priority of vaccinating Chicago as a nucleus, as a crowded place that we have all these individuals living, and where outbreaks were very high at the beginning of the pandemic. So we were distributing directly to our pharmacies, to our partners, and from hospitals going to our seniors, which were in 1B, and before that, those living in long-term care facilities or nursing homes. And then we had our pharmacies helping us with seniors, strike team, and vaccinating employees, which were part of the 1B when we were vaccinating essential workers, first line essential workers. And then we have providers, seniors, and school systems. And from the city directly, we were operating strike teams, and we still are, and mobile units. And we were doing temporary clinics at what we call Protect Chicago Plus. So I'll give more information. That's an initiative that we have to try to get to the vaccine to the people that need it the most, and the way we can meet them exactly where they are and decrease barriers to receive this vaccine. And then we had our fixed pots, and now we have our massive vaccination centers here in Chicago in different places, locations to facilitate to the most needed communities to be able to access this most needed vaccine. So we had 3 modalities. We went initially just in a distribution of 3 modalities. We had our fixed pots, which were able at the time to vaccinate 500 individuals. And remember that we had limitations of vaccine. And we had our mobile pots, which were very good at special events happening at the community, our churches, libraries, places where we understood it was important to get there to the community in a hyper-local approach to attempt to bring down all those barriers that our most vulnerable communities face when getting the vaccine. And then now we also have our strike teams, which are a group of 5 individuals going to the homebound programs that we have launched in last month. We were vaccinating seniors, and it was senior month. So we did that. And now we also have in an attempt to get creative and bring vaccination to places that are needed the most. We had the Vaccination Bus from the CTA. It was modifications, as you can see. Seats are different, everything is different. So we just park at the places that they're most needed to get the vaccines without appointments or without any type of documentation. Just go in there, give us the basics so we can have you put all the information on iCare to follow statistics, to follow all those things that are needed and requested by the federal government, but to minimize any barriers to our constituency, to our community members. And this was happening in our communities more highly hit. So I'll explain how we decided which were those communities more highly hit. Another way that we were also vaccinating, especially during 1B, was getting to the places that our most vulnerable community were at, which are the working places. Well, we had a huge number of undocumented immigrants. We also had people without insurances, and we also had our refugee population working at these places, and they feel very threat going to any of our clinics because of the militarization of the government systems to administer vaccines. And we understood that was an important barrier. And so forth, and therefore we partner with our healthcare systems in our pharmacies to make it a strike team, go to these places and vaccinate everybody there, or become vaccinators themselves. So if they had these working places had clinics for employees or nurses going there, we make them vaccinators so that people can feel comfortable in a non-threatening environment to get the vaccines with the coworkers and for those communities that I mentioned. And now the most important part that we started initially before the vaccines with Protect Chicago Plus. And this was an initiative going there to the communities more highly hit. And we decided that using what we know as COVID and COVID and community index, vulnerability index. And it's taking those social determinants of health of these individuals, in addition to the devastation of COVID-19. And we came with these index, and the higher the index, the more likelihood, these communities needed help to be vaccinated, because otherwise they wouldn't stand the same chances, fighting chances as any other of our communities here in Chicago. And we did it in a hyper local approach manner where we noticed, where we saw those outbreaks happening, because if we would have taken it by zip codes, we would have not had the vaccines to be able to deliver. So we were doing it as to communities where the devastation was the highest at those focus places, vaccinating there, and not only saving lives at the time, but also containing the spreads, because these are the places we had our highest COVID-19 spreaders in our city of Chicago. So initially we started with 15 plus. I don't know if anybody is here from Chicago, but it's West Englewood, New City, Gage Park, North Lawndale, South Lawndale, Chicago Long, Englewood, Roseland, Archer Heights, Washington Heights, Austin, Montclair, South Daring, Belmont Cragen, and Humboldt Park. And then from there, we moved also to vaccinated the 26 first communities. And we did it in approach that it was boots on ground, door to door knocking, census type, to address the individuals at their home. We were vaccinating everybody without following prioritization lists, because we knew if we left people behind, it was not going to make any difference. It was not going to be impactful. So we were vaccinating whole families. We were doing events. We were knocking at their doors, enrolling them right there so they can all get the vaccine, addressing any issues, language issues, cultural issues if they have problems with accessibility to information, and bringing down the digital divide. So we went there, we did it ourselves. And we were doing these huge campaigns initially to give information, later on to vaccinate in this same modality. And then that same program we called Protect Chicago Plus. And this is what I'm showing right now is the index that we use, or the indicators of devastation in these communities, which were socioeconomic status, if they were low income, educational attainment, if it's low, occupations, if they're essential workers, or representation of essential workers, or they had no job at all. And then household composition and disability, anybody, all those households over than 65 or younger than 17, which were not, contributing to the income of the home, single parent home, those were taking into account minority status and language, racially marginalized groups with limited English proficiency, not getting access to the information in the right language or cultural background. And then house type and transportation, if they were living in the middle of transportation deserts, where they didn't have any access to meaningful quality public transportation. And then we took into account epidemiologic factors, which means the degree of illnesses, cardiovascular, respiratory, immunocompromised, obesity, diabetes, people dying from flu, high hit flu cases and mortality related to this disease, and also high population density in this area. And the healthcare system factors also we took into account if they were in the middle of deserts of quality healthcare. That was also taken into account to calculate this index. So we were taking into account that vaccination is the important, and we thought of it as at the end of the pandemic, but keeping the measures to stop the pandemic was as important. So we took a lot of time and effort, and we partnered with community organizations that were grounded, trusted faces, to make sure that the information was getting in the right way by the right people. And that's hyper-local approach that we did for this 15 plus initially. And then we moved to this 26 plus communities protected by this program, where we were dedicating a lot of resources to make sure that no one was left behind. We have like right now we have like 11 or more operating in colleges, and we have small places. We have our strike teams where now want to go door to door, revisiting all these homes that they decided not to get vaccinated to make sure that I'm sorry, make sure that no one is left behind. This is if it's a lack of information. I know the J&J situation was devastating to already a fragmented trust in the community. But we want to reassure to our community members that there are options out there right now. They can decide which vaccine they want to get or they prefer to get because they're no longer limited. And it's because the demands are so low that now we have extra supply to give it individuals. Now our partners of the communities, doctors, clinics, providers, strike teams, our programs. We have our homebound program right now working with J&J. And then we have other places that we provide also the vaccine because we know initially there was a inclination and a preference for J&J. So we're offering in our clinics as well as we're offering Pfizer for most of our part. And for the clinics of our hospitals and different settings, we're offering Moderna too.
Excuse me, Dr. Luna, but we're going a little bit over time. It's super
Okay, so I'll
interesting
leave it
and
here.
very important.
Yeah, because I just wanted to share with you guys like different aspects that we have done and we continue to do because right now we're facing the terrible reality. People just don't want to go and get vaccinated. So now we're doing these committees, sitting down, brainstorming with community members, with our faith leaders, with our community leaders, and sitting down there to see what is the next step in Chicago. And we're doing initiatives that we're giving out freebies, the travel ordinance that we have here are waived to people that are vaccinated. We're giving free tickets to outdoor concerts as we open up our city, given that our cases are decreasing significantly. So that is a happy thing, but we still have a lot of ground to cover. So all this information we have are in our website, which is chi.gov/COVIDvax. And I'm sorry it took a little bit more.
No, we really appreciate it. Very in-depth. I'm very surprised and very hopeful at the in-depth response that Chicago has to COVID-19 vaccine distribution. So thank you for that. Next up for our speakers is Dr. Shanjani. So give you the floor.
Thank you, Nabil. And good evening, everyone. Dr. Luna, thank you so much for that presentation. And I think that in my experience, which I'm going to share with all of you tonight, you will see some trends of what you were talking and what you have been finding in the city of Chicago as well. So as it was mentioned at the beginning of the presentation, I work with Public Health Medicine in Dane County in the role of bilingual health education coordinator, and this is with the communications team. I'm going to speak about my experience working in this response, sharing information, creating messaging for our Latinx and our other Black and Brown communities. And as health educator, as health communicators, what we do is that we use communication strategies so we can influence and we can empower people, populations, and entire communities so they can make healthier choices. And within those health education activities, we are looking at the overall goal of improving and doing health promotion and disease prevention program. So going along with what Dr. Luna was saying, the materials that we develop around health education must be culturally appropriate and they must be tailored to the intended audience that we want to engage. So we can ensure that we are really able to connect and relay the messages. A very important part of that is building relationships in the community so we can effectively communicate with them. And this should be a two-way communication, right? Not only us putting out information, but also authentically sitting down with communities and having conversations, listening to their concerns and validating their concerns. As Dr. Luna was saying, there are many reasons why people who have been victim of racism, and particularly in healthcare settings, could be hesitant to getting the vaccine, right? We're talking about hundreds of years of inequities. And in our case, for the Latinx community, we also have other added components like the language barrier or the fear of the systems of the militarization and how that power dynamic plays. So we got to be really mindful of that. We have to be understanding on how that plays a role in the mistrust and the distrust that our communities have in the vaccine. I think it is really important for us to take ownership as people that work in healthcare settings. uh, do not take that on a personal level, but just like recognizing that we are part of the health system, right? And there are those reasons why people might be skeptic or might be not open to have the conversation. So having a humble approach when we are engaging with our communities is really important. What I have seen in my experience in this response, uh, educating and informing our communities about the vaccine, is that it does take multiple interactions to be able to engage with our communities. Um, there is a lot of complex information about the vaccine, and not only about the vaccine, but about the virus in general. So, making sure that we speak in a clear and simple manner so people can feel that they are empowered with the information to make the decision of getting the vaccine. When we are engaging with our community members, um, not not going with a mindset that we're going to be like educating them, like I'm going to lecture you on this. It's like we're going to have a conversation about the vaccine. I'm going to share information that I have, and hopefully we can help dispel some of the myth and some of those conspiracy theories that people are consuming through different sources, social media, and just like word of mouth, the different experiences that people have with health systems. So that is also something really important. In Dane County, Wisconsin, the population is about 550,000 people. And as Dr. Luna was showing in her graphics, we also have our race and ethnicity breakdown of about 85% white, and then about 6.5% that identify as Hispanic or Latinx, and about 5.5% that identify as Black and African American. So we can see some commonalities there. And also, we saw, even though our communities are minorities in proportion of like representation, we also saw throughout the pandemic a more cases and also hospitalizations and death within our communities compared to what we really are um, in the population. So I believe that this pandemic has really uncovered many of those disparities that we working in public health or working in the community were aware of. And this pandemic is also opening up the conversation about those disparities and how we can better approach and how can we improve our systems, hopefully. That is my hope, that these conversations continue and they are more intentional in helping our community members. Right now, we are doing a lot of, again, conversations with the community, because as we opened up the availability of the vaccine, we also have seen a decrease in the vaccine uptake, especially in our Black and Brown communities. And something really important that we are doing in Dane County that I think is similar to what Chicago is doing, we have a central mass vaccination site. But speaking about accessibility, right? How can we make vaccine really accessible for people that have to go to work, have different schedules, and people that do not feel comfortable driving to this centralized location? So decentralizing, really going deep in our communities, having mobile vaccinations, having a very collaborative approach with other vaccinators, with our health systems, in regards to creating messages that are aligned, that are the same, but also how do we work together to make sure that we are covering those places where there is a gap in the access to the vaccine. So having those intentional and collaborative approach can really help our communities in bridging the education and also the accessibility piece to the vaccine. I know that we're going to have like a Q&A, so I'm going to stop there. So Dr. Salinas can also share about his experience, and then I'll be happy to answer any other questions.
Thank you very much, Dr. Shanjani. Um, yep, Dr. Salinas, if you can give us your perspective as well.
Thank you very much for the invitation, and thank you very much, Dr. Luna and Dr. Sanjani, for sharing your experiences. I think that that you have outlined already a blueprint and a roadmap for counties and states that do not have large minority populations and may struggle to understand their needs and to reach them. So I think that the first two presentations were fantastic, and there are many, many lessons that states like Iowa can get from this presentation. So I am based in a hospital, and I'm also, or I was also involved in the infectious diseases advisory committee to the state of Iowa, figuring out what would be the best allocation strategy for vaccines early on when they were not as available. So I'm very proud that we were able to prioritize, besides, of course, people over the age of 75 and over the age of 65. We very early on recognized the burden of disease among minorities, among migrant workers, and among meat processing plant workers. And we were fortunate enough to be able to prioritize them next to school teachers and some other frontline workers, including first responders, policemen, etc. So that was good, but as was mentioned early, that was prioritization to get access to a system that still requires uh, health literacy, computer literacy, access to computers, access to a car, having the opportunity or the means to sometimes drive 1 or 2 hours to get to a vaccination location that may be available. So I think that Iowa is still in the transition phase. We have been very effective in vaccinating those that were very eager and had the means to access the current passive system. But Iowa is in the transition point in which we're going to have to start launching the strategies that Dr. Luna so well described earlier, to be more proactive, to reach people where they're at, to reach them at home, to reach them at work, to reduce barriers, to reduce the need or to eliminate the need to register online ahead of time. So I think that, again, Iowa has a lot to learn from places that have more robust public health infrastructure and experience. but I think that Iowa will be able to get there. And something else, another strategy that is used for other vaccines, such as pneumococcal vaccine and influenza vaccine, is utilizing the currently built health infrastructure. Hospitals, clinics have not been fully integrated into the vaccine deployment effort. And I think that we can participate by offering these vaccines when people show up for care in clinics, emergency departments, or during their hospitalization, again, as we do for flu and pneumococcal vaccine. So I still remain optimistic that we have vaccinated a large proportion of Americans already. And I think that in the coming weeks and months, it will be harder, yes, to continue approaching 100%, and it would require more effort. But at the same time, that will be accompanied by decreases and steady decreases in the incidence of COVID in the United States, including the minorities that we're discussing. So again, I was mostly a proud and eager listener to both of the first presentations, and I'll be happy to address any questions and to pose some questions to my fellow panelists as well. Thank you.
Thank you very much, Dr. Salinas. So with that, we'll open the floor to any questions. Just type them in the chat, say them out loud, unmute, and we'll get ready to go.
I'll also start typing questions that were asked before the event during the registration. I'm posting one right now, and it was from Julio Arnao Gonzalez. And you can see it right there. I can ask it if you want, Nabil. So how are we reaching to leaders in the Latino community to improve vaccinations numbers in that community? And that was intended for anybody that wants to tackle it.
Well, I can provide some of the work that we're doing in Dane County. The Department of Human and Health Services of the state of Wisconsin has provided funding for community-based organizations and leaders that want or are going to be doing work on vaccine education for communities of color. So at the health department, the way that we are supporting the work of these leaders or community-based organizations is that first we are participating in a collaborative coalition with health systems in which we are creating messaging, and that is like FAQs. We're also participating in community conversations that are led by these community-based organizations or leaders that have received the funding. So we create content and we help them with the content that they need or they see appropriate depending on the audiences that they're going to be working with. And we also are providing like other type of technical supports. Like, for example, there is an organization that received funding. We have been meeting with them about giving them some advices on things that might work for the type of funding that they have received. Another thing that we have been doing is engaging with community health workers, which are really agents of change in our communities because they are embedded in the communities. They have already the trust of the community. And to me, that has been one of the most humbling experiences. I had the opportunity to participate with a group that when I started to interact with them, the group per se was already skeptical about the vaccine because they are part of the community, right? They also have experienced like negative experiences with the health system. They also have family members who have had those experiences. So they were already hesitant and they were skeptical. And in the first interactions, it was a lot of listening. It was a lot of validating their concerns and brainstorming about what is the best way I can communicate with them. Because even though I am a person of color too, I work for a public health department, right? So that's the way I am viewed as a person that works for the government. And just like going back to our team, making sure that I am following through with their requests. If they had like specific questions, uh, I am bringing the information back to them because I am building the trust with them. And I must say that when it was their turn to get vaccinated, all of them did get the vaccine, which is like I think was a huge success for us and for the community. And now they're doing community conversations and they're going door to door. They're talking to their neighbors. They're helping register people because that's one of the bigger barriers that people are experiencing, the registration process. So they have tablets. They go and they help their neighbors, their families to get registered for the vaccine. So just like going back to what I was saying initially, just like reaching out in an authentic way, in an authentic manner, being humble and sometimes even vulnerable, taking ownership on the damage that has been done, and just like looking forward and how can we better continue to support these groups and when we reach out to them, following through in and make it two-way. Not only we're going out and giving you this, but like we're not extracting information from you either. We're having a collaboration.
I could add a little bit more to that too from the Chicago side. Well, since the very beginning, we have had amazing relationship with healthcare systems, as Lourdes was mentioning, with community-based organizations, with community-based members. So we had since the very beginning, we started with the Rapid Equity Rapid Response Team, which is a task force with all those representations where the community is more highly hit, and they were coming with suggestions, recommendations, especially to break through, as Rude was mentioning, from decades of mistrust on governmental and also on science itself. So receiving the vaccine sounds like an experimental thing. So that was one of the biggest challenges to break through in communication and bringing everyone on board. So we also had our relationship with the media. So we went to our news anchors, our news businesses and administrators, and started. We have a segment now in ABC7, and also the Univision, to answer questions related to vaccine safety and to answer all those questions that you have, like who is candidate, who isn't, why this, why that. So the community had like ample space to express themselves, and we did amazing tons and tons of webinars with alderman approaches to individuals and community coalitions, working with all these representative of Latinx communities in African American, because this is the community with the resistance, with the hesitancy, with the mistrust. I mean, if you see our numbers, Caucasian, they lead the charts and getting vaccinated and moving up to their health and taking ownership, and because they're privileged, they have more privileges and different means than the rest of our population, which has been scarred by traumatic events in the past, sterilization. When they went to give birth, they ended up being sterile, and because of other Tuskegee for African Americans. So we're talking about communities, entire communities that have survived with minimal governmental investment. So trying to bridge the gap of communication or gaining trust, you can see it. We haven't advanced that much if we look at it right now, when half of the population is not being vaccinated. They just don't want to. And so we're talking about a lot of steps, a lot of money, a lot of resources, a lot of time, dedicated time, and an amazing people, amazing collaborations, and a team that has stepped up to the front and make those connections possible. And we continue to work. And right now we're working with all our business We have even vax and relax, which means that go to your barber, go to your nail parlor and get your nails done for free and get your haircut or a hairdo for free. And then we have our bars now giving beers for free of people that get vaccinated because they can go in. And we're amplifying or increasing our indoor capacity with another members of the community. Navy Pier, we just opened up over this weekend, 25% outdoor restaurants, and there's a lot of perks, free tickets for concert in summer, and we're talking about free tickets for other activities indoor if you're vaccinated. And people vaccinated are not going to be counted to the limitations that they have of 50 individuals for weddings, for concerts, for anything that is indoor churches activity. If you're vaccinated, you go a different line. And it's not to discriminate even further, it's to incentivize. And we're trying to do it with our youth, and we're working directly with our representative of all these with our aldermans, as I mentioned, with congressmen. We're talking about elects. We're talking about leaders, faith leaders of the community. So it has been a vast, like a plan in place, and we continue to work on that, and we still are halfway there.
Thank you. Dr. Salinas, did you have anything to add or any questions of your own?
Well, not really. I've participated a little bit in outreach and in some radio interviews, etc., trying to reach the Latino community. Also partnering with our state health department to ensure that we remove barriers. For example, some uh, vaccination locations in Iowa were requiring initially some form of documentation, either social security numbers or a driver license to be able to get the vaccine. So we were able to discuss offline and remove that requirement. Again, any of these little barriers that we put becomes a huge problem to get to 100% coverage, and it's just unfair. And I think that our state health department has been very receptive, even though overall the political environment plays a huge role in the vaccination and public health strategies that are taken. More conservative states will have a harder time implementing these great strategies that Dr. Luna and Shanjani described earlier. But there are always ways. Of course, the civil society has to vocalize, and we need to advocate for people. But yes, the challenges persist, and local leaders play a huge role. And again, it's a battle that has to be fought.
Thank you. Say, were there any other questions that were typed in the registrant?
Yes, I will include, and we probably have more time for one more question, probably, just for the sake of time. So this one's more focused on language access and equity. So with quickly changing information on websites, hotlines, etc., how can we ensure and promote more language access and equity, and how do we keep those things updated and make sure that everybody's getting that information consistently?
Yeah, I can speak very quickly. Like from our department, I'm the first Latino doctor working as a medical director in Chicago. So that is like, having a representation, a voice there, to me has been incredible. I'm blessed because of that. And one of the things the city has done to try to improve communication with Hispanic or Spanish speakers Hispanic and Latinx communities, is to have me now participating at the pressers. So I take the remarks and I bring them up in a linguistic and cultural manner that people can understand, and they see their face. So it's building trust, having that information. By having the information in a concordant way, the way that we speak it and we understand it, and seeing a Latino face right there, it's building trust and presence in our community. So that has been some amazing steps, and still a lot of ground to cover, because I know that some of the information that we get, you might notice that it's not in Spanish. We do have a translate an individual for hearing impairment up there that's always there, which is a very strong sign of the inclusivity of the city and trying to make it, bring equity to everybody to understand the information and get the information regardless of your incapacities. But having now that part, I think it's a very strong stride to promote equity in the communications with our communities, which Ms. Truss is like the attitude that we have there.
Yeah, I cannot agree more with Dr. Luna. It is a huge undertake. We do need to have more representation of our Black and Brown communities in healthcare. And I think that's why it's so important that groups like the Latino Medical Student Association, MOLA, and other groups that are fostering that type of work, incentivizing and making sure that students go through their degrees. It's so important because we are in the work, and as Dr. Luna said, uh, sometimes it can feel like you're being tokenized in a way because there is no more resource. You are like probably the only person that speaks Spanish in your department or in your whole building. So it is really important that we continue to encourage our students to go into healthcare so we can have more representation. Um, Another thing that is important is like to recognize the diversity within our own Latinx community. So when we talk about like language access, translating things into Spanish, making sure that it's like a neutral Spanish, right? Because I am from the Dominican Republic and I might say something that does not resonate the same for someone from Colombia, for example. So just like those are cultural aspects that as we get more representation, it can be, we can work towards that. But definitely things are changing very rapidly. It's difficult to keep up when you are probably the only person doing the translation or doing presentations. But we, I think it's getting better, but there's still a long way to go.
Yes, I'll jump in, and I agree. Even though at the University of Iowa Healthcare, we have created content in Spanish and done some Facebook Live events in Spanish. It's I think it's still insufficient. The Latino community in Iowa is underrepresented in any aspect of media, on TV, radio, internet. So it's a challenge, and I don't think that when policies are written in a state like Iowa, I don't think that these groups and minorities are being considered. Most policies are being written thinking of the predominant groups. The white population is predominant in Iowa, and it's understandable, and it's good that they are thinking about that population. But we have to be proactive in thinking of other communities that are also an important part of the workforce of the state, are citizens of the state, and but pay their taxes, and they deserve fair representation in decision making and policy making in the state.
Thank you so much, Dr. Salinas, and thank you so much to our panelist speakers, everybody. I think now would be a good time to wrap it up. It's already 8 and being mindful of everyone's time. So again, thank you everyone who came out. Thank you to our panelist speakers. If there are any lingering questions, I can reach out to our speakers. Let me put my email in the chat. And if you have any questions for our speakers, please just email me and I'll forward it over to them. Again, this session is recorded and it's going to go out to MOLA membership. It's going to go out to the University of Iowa schools. It's going to go out to anyone who requests it. So please share it around when when you get access to it, because this is very important information. Again, thank you. And if anyone doesn't have any other remarks or concerns, then we can end it then.